Welcome. I'm Dr. Carol Dellinger. I'm the faculty advisor for the chronic pain opioid use disorder track at the IU Family Medicine Residency program here in Indianapolis. Just a little about me. I've about 20 years of experience of pain management and have recently developed an interest in opioid addiction as well as a recent certification in acupuncture. I helped start the chronic pain opioid use disorder track in 2022, and we were fortunate enough to have 2 interested residents right out of the gate. I'm joined today by those residents, our first 2 track graduates, Dr. Danny Lavera and Dr. JT Barton. So what have you gotten out of the chronic pain opioid use disorder track, and how did it impact your plans for practice?
I think the track in and of itself provided a really good opportunity to see a diversity of pain and addiction through our specialty tracks. I thought, in particular, the buprenorphine clinic was really helpful for me, kind of understanding the different medication options and kind of treatment duration that patients could expect to be on, and then how to handle social stigmas as part of that training. So,
for me, the big thing was getting more comfortable around having that conversation about, opiates, tapering opiates, or alternatives that we might have, and just having exposure to patients with chronic pain and talking about those different modalities just gave me a bit more confidence to speak with more conviction about these things with them.
What is the most surprising thing you learned or experienced as part of this track?
so for me personally, Dr. Dellinger was part of the chronic pain track and supplemented with buprenorphine, was working with like an integrated care team. So that was something that I'd never experienced ever in my life, and I think what I found was how valuable having different specialists in different fields with physical therapy, chaplaincy, social work, and see how an integrated team can really affect and help a patient.
Related to what JT was saying, I was really surprised by how many people took me up on alternative modalities for their pain, or that people were even interested in trying to taper down or wean down. Those would be the most surprising things for me.
So what are some memorable moments that you've experienced during the track?
For me, it was we had a patient who had been involved with care in the hospital, lots of medical comorbidities, but then also had chronic pain that they were on opiates for. Being able, when they came back into our clinic for the chronic pain aspect of it, having that connection, being able to refer back to, the social situations that we were dealing with in their hospitalization and how that was affecting, the concept of that total pain. The buy-in and the sort of connection that I had there was something that I very much, will remember and appreciate, because then I would see them in my own clinic afterwards, manage the rest of their medical comorbidities, and I found that was such a therapeutic relationship to have with the patient, that sort of longitudinal experience with them.
For me personally, I think one thing that you find in chronic pain is how the social setting as well as like psychiatric health is really vital to helping pain and kind of seeing patients where we would address their social needs as well as like their psychiatric needs and how that would impact pain was something that was a kind of nuance for me before I started the track, but now you see how vital it is day to day.
How has your schedule been different than non-track residents because you were in this track?
Yeah, so the main difference that I can speak on is just having more opportunity in the specialty track clinics. So with buprenorphine on Monday mornings and co-pack on Friday afternoons, we have more opportunity to kind of immerse ourselves in that setting and also have more thorough discussions about treatment plans and appropriate regimens patients should be on that you may not necessarily have in a continuity clinic. So more opportunity to kind of learn and dissect and grow in your foundation.
And then in addition to the clinics that we have, we also do have those regular track meetings where we discuss, journal club and do didactics on pain and opioid use disorder topics.
So what are the challenges of being in a track, specifically this track, and can you do multiple tracks?
Yeah, you absolutely can do multiple tracks. I'm on a few tracks in addition to this one. The one thing to watch is for each of your tracks, are the clinics coinciding with each other or overlapping? That's the harder thing to sort of tease out. It takes a little bit of planning. But other than that, the after hours stuff like the didactics or the journal club, that's pretty flexible and hasn't really been an issue for me in terms of finding a time that works well with the rest of my tracks.
And this was the only track that I pursued during my residency, and I found the journal club didactics very helpful. Only meeting once a month is not a big time commitment, and actually they're pretty enjoyable. Meeting with Dr. Dellinger and Danny was pretty memorable with our dinners and just learning about opioid use disorder and chronic pain. So it is very doable, and there's not a lot of work outside of your day-to-day hours.
So how have the specialty clinics been helpful for your training in chronic pain and opioid use disorder? And is there an advantage getting this training in the family medicine clinic setting versus other environments?
For me, the interprofessional, the specialty clinics has been a huge eye-opener. There's, from my experience, been a huge difference between telling someone to go to physical therapy or go get evaluated at physical therapy and then having versus having a physical therapist walk into the room after me, do their evaluation, make the recommendations, or having the chaplain go in, have a chat with the patient right in the clinic during the appointment, and get a completely different story or piece of the puzzle that I was not able to elicit from the patient. And for me, I find that incredibly rewarding, having that sort of holistic picture in terms of being able to talk to people. We talk about motivational interviewing, all that sort of thing feeds into it. In terms of the benefit of having it in the FMC clinic, I personally am a homebody, so I really appreciate having the familiar environment in terms of the clinic. But then the other really cool thing is that once people get stable on their regimens, or you feel comfortable taking over their care, you can then transition them to your own personal continuity clinic. And I've had a few patients that I've been able to do that with, and that's enjoyable and rewarding.
Yeah, to echo what Danny has said, I think more speaking from the opioid use disorder in the buprenorphine clinic is the biggest thing is that there is such a stigma about opioid use disorder, and one of the really neat things that I don't think many specialty care clinics or clinics in general have is a behavioral health coach, and I thought that was really vital in our treatment plans with patients, is getting them on board with a peer recovery coach, I should say, and say establishing that trust that we want what's best for you, and we have someone here that can help talk through those tough moments that we might not as providers have experienced, but try to get a full kind of like encompassing care plan that the patient actually looks forward to coming to our clinic to seek treatment as opposed to putting in a referral and hoping for the best. So it was really rewarding for me to see those patients come back rocking and rolling and really on board with their care plan as opposed to just taking the advice from the doctor.
So what sort of scholarly activities did you participate in related to the track?
Related to the track, I think one thing that became very evident early on in our initiation of this track was that Danny and I were more or less kind of the resident experts of buprenorphine and chronic pain. So one of the rewarding things that we did kind of as the track progressed later on in the year was present a formal didactic on buprenorphine as well as methadone, and kind of there's a lot of hype surrounded around buprenorphine and buprenorphine clinic, and we tried to kind of calm the nerves related to prescription and kind of understanding how the medication works and how to prescribe it. And I thought it was one of the more rewarding presentations that I've ever given, and then also one of the probably more engaging didactic sessions that we had, because it was a very kind of foreign and unfamiliar topic that most of our residents hadn't had a lot of exposure in. And to second that, something that Danny and I both, to kind of hone our education level and understand kind of what we were doing in terms of opioid use disorder treatment and chronic pain, was watch the PCSS webinars and kind of better hone our foundation in addiction medicine and opioid medicine.
Another thing that both JT and I had the opportunity to do was present cases at Project ECHO, which is a sort of national case presentation conference that happens virtually. And that was a really rewarding thing, because it's not just presenting a case, it's if you do have someone that you do want expert opinions on, because it is a multidisciplinary audience, and try and get some traction in terms of what you might try differently in terms of therapeutic interventions. That has been a great resource as well.
So why would you recommend that family medicine residents consider applying to the chronic pain opioid use disorder track?
Chronic pain and opioid use disorder are not going anywhere anytime soon. There is a big part of my regular continuity clinic where patients always have something to do with pain, being able to talk intelligently about it, and make a meaningful connection with patients regarding pain modalities that we're going to try, the trajectory of their pain. All have been valuable tools for me that I learned through this track, and that's why I would recommend it.
Yeah, and Dr. Dellinger, I know something that we talked about was at all of the various clinics that we rotate through throughout our residency, is that there is a component, as Danny said, of chronic pain in every single clinic that you visit. So I think for me is like the biggest takeaway is like being able to confidently understand, like, these are the medications and this is why we're trying to optimize their pain. And then ultimately is, if we've tried to optimize pain and the medications are max dose and we need to look into different things, we've had a lot of didactics of possible interventions and appropriate referrals for interventional pain management, and just kind of being able to meet the patient where they are and address all their concerns in a competent manner, I think is like the biggest thing that's helped me with this track.